Hello, and welcome to this evening's RLI Power Hour webinar titled Workforce Challenges, Tackling Long Report Turnaround Times. My name is Dr. Jennifer Nathan, and I'm co-moderating this evening session with Dr. Bob Pyatt as we are co-chairs for the RLI Power Hour webinar series. So there's just a few logistical items that we do want to go over with you before we start this webinar this evening so that you know how to better participate. So when you join through the Zoom platform. And what you will find is the Zoom control panel at the very bottom of your Zoom window. And there's just two icons that we want to draw your attention to. The first is the chat icon. So the chat icon is something you would type in if you're having some sort of technical concern, and you type in your concern. Our staff will see it on our end, and then we will get back to you to help you resolve your issue. The main one we do want to point out to you is the Q&A icon. The Q&A icon is one where you would type in questions that you have for our faculty. We'll collect them and we will answer them when we get to the dedicated Q&A session at the very end. And one last item that we do want to mention, this webinar is being recorded, and that also includes the questions as part of the Q&A session. So we do want to make you aware of that. All right, so I'm now going to turn things over to Dr. Pyatt to introduce the site's this evening's faculty. Dr. Pyatt?
Thank you, Jen. And we have quite a faculty lineup here for everybody tonight. And I'll start off with Dr. Mike Bruno, MD, MS, FACR. Dr. Mike Bruno is a professor and vice chair for quality and safety, and he is chief of the section of emergency radiology at Penn State College of Medicine, Milton S. Hershey Medical Center in Hershey, Pennsylvania. He is currently the chair of the ACR Committee on Emergency Radiology for the GSER Commission and is a member of the Outreach Committee of the Patient and Family-Centered Care Commission. And he was recently named a counselor of the ACR representing the American Röntgen Ray Society. Dr. Nicholas Galante is the medical director of informatics and integrations at Radiology Associates of North Texas, which is the largest physician-owned private practice in the United States, covering the majority of the Dallas-Fort Worth Metroplex, as well as other regions of Texas. Nicholas is also a member of the group, his group board of directors. He is trained in musculoskeletal imaging and body MR. Frank J. Lexa, MD, MBA, FACR, is an academic neuroradiologist at the University of Pittsburgh, where he is a professor and vice chair for faculty affairs. At Pitt, Dr. Lexa also works in several capacities for UPMC International, and he also teaches at the Katz Business School. Dr. Lexa is the Chief Medical Officer of the Radiology Leadership Institute of the ACR, and he is also the chair of the RLI board. He is also the current chair of the ACR International Economics Committee, and he is a member of the ACR International Commission. Dr. Lexa has served on the Board of Chancellors of the ACR for 2 terms as the chair of the Commission on Leadership and Practice Development. Dan Ortiz, MD, is a private practice musculoskeletal and general radiologist with Summit Radiology Services, BC, in northern Georgia. His involvement in the ACR includes serving as the past chair of the resident and fellow section and membership on the Council Steering Committee, the College Nominating Committee, General Small Emergency and Rural Practice Commission's Economics Committee, and the Commission on Leadership and Practice Development. Ben Strong, MD, completed his residencies in internal medicine and radiology with a fellowship in MSK and body MR. Ben has worked for 3 years as an emergency physician in the past and then as an academic and private practice radiologist. He has worked for Virtual Radiologic for 16 years and has been its chief medical officer for the past 7 years. Ben is licensed to practice in all 50 states. It's a pleasure to bring these fantastic faculty to you this evening, and we'll start off tonight with Dr. Mike Bruno. Mike?
Hi, thanks. It's a great introduction. Thanks for inviting me. It's great to be here. And I'm going to start the ball rolling with what I think is the explanation for why we're having this RTAT inflation, where our RTATs are going up and we can't seem to get a handle on that. So I'm going to share my screen. I hope you can see my slides. It looks like you can. My talk is entitled "The Current State of Supply and Demand Imbalance in Radiology and Its Downstream Consequences." And since I'm an academic, I'm going to give you an academic perspective. Let's see. Trying to get the slide to change. Okay, there we go. Basically, we're dealing with a widening mismatch because the demand for imaging is increasing exponentially. And part of that is because we have an aging population with a higher disease prevalence, and that's not just among radiologists, although the average age of radiologists in this country is over 51. We also have an epidemic of overtesting, and there's quite a bit of what I call waste, and what some people euphemistically refer to as low value utilization. And you all know what I mean. So the supply of radiologists, our capacity, is declining. And part of that is this phenomenon known as the Great Resignation. And we've seen a lot of colleagues retire early, go part-time, and even younger colleagues. There are tight limitations on the training pipeline. We can't seem to train enough radiologists, and we can't increase the number of radiology trainees very quickly. So when you combine those two, we're having a bit of a decline in our supply and our capacity. There's a move toward part-time remote work, increased concern for work-life balance, especially among the new folks entering the workforce. So we are seeing this exploding demand for imaging and a dwindling capacity at the same time. So this is sort of the backdrop of our current state. And this is what the average radiologist looks like in the average morning coming in, having your coffee. You're already underwater. We're sort of practicing at the bottom of the pool. So there's an emerging literature that's addressed the rising use of medical imaging and questioned whether we're doing a lot that doesn't really add that much value and that I would call waste. Of course, this is not entirely under our control. We don't order the studies, but we're kind of drowning in a lot of studies that have limited clinical utility. Here's a paper by Rebecca Smith-Binman talking about the imaging, the use of imaging has skyrocketed, and it's hard to pinpoint what's responsible. We see that in this recent paper from AJR, that it's becoming increasingly common, and I see this in the emergency department, where even minor traumas, an elderly patient falls off a chair, will typically result in a CT scan of the head, neck, chest, face, entire spine, and X-rays of all four extremities in great detail, and seemingly without bothering to do a thorough assessment first, just order everything. Part of it is, I think, due to an increased amount of care being provided by non-physicians, and they perhaps are not as comfortable with their clinical assessment, and so they tend to rely on more testing. Of course, we've talked about this many times in many settings, the seemingly fanatical belief that emergency doctors have that every patient has a pulmonary embolism until proven otherwise. So we have a tremendous volume of CT scans for suspected pulmonary embolism in emergency departments. And we actually calculated a very high likelihood that you would get a CT scan for pulmonary embolism just by walking in to the emergency department. And there was an old joke about a series of old jokes, you may remember this, where they all start with a guy walks into a bar with a parrot on his shoulder. Well, if that guy walked into the bar, walked into the ER with a parrot on his shoulder, then someone would very likely want to do a CT scan for pulmonary embolism for both of them. A lot of analysis has gone into the overuse of diagnostic testing, but it's a big problem for us. And then Matt Davenport from the University of Michigan published this excellent paper talking about how chasing incidental findings is also a source of low value care, because most of the things we find are not going to be of clinical consequence. And then there's a new kid on the block, opportunistic screening. And this is partly driven by the availability of AI, where we can segment images and look for things that no one ever asked for. And this is certainly going to be driving utilization in the future. Um, so at least 30% of medical imaging studies performed in the US are not medically necessary as defined by the ACR appropriateness criteria. And some people think it could be as high as 50%. I actually had a group of 10 medical students spend a day where five of them were in the emergency department, and every time a ER doctor ordered a CAT scan, they asked him, him or her, why are you doing this? Do you really think it's needed? Do you think it's needed stat? Then they asked the radiologist who was reading them the same questions and compared them. We largely agreed. And the number they came up with was 42% of the studies being ordered were probably unnecessary. They were outside of evidence-based guidelines. The ER doctors admitted that, but they ordered them anyway. And we actually had a very high level of agreement between the radiologist's impression and the ER doc's impression, but that did not stop them. This is a fun graph because it shows from 1995 to 2007 how we had this, truly exponential curve, in the growth of the number of ER visits with CT in millions. And can anyone guess where it is now? It was 16 million in 2007. That's right, over 100 million today. 100 million CT scans ordered in emergency departments per year, and it's increasing by over 11 million a year over the past decade. So things like CT for headache, minor trauma where the patient has no obvious injury or complaint, suspected pulmonary embolism, and all kinds of miscellaneous things, vague abdominal pain, whatever. This is from a nice paper. It was in AJR, looking at the various kinds of CT scan growth in emergency departments between 2011 and 2018. It's just a continual upward climb. More than 38% of patients with low-risk headache are subjected to unnecessary imaging with no change in management. In fact, only about 1% of scans for atraumatic headache will ever yield any kind of actionable finding. And it's very clear in the guidelines, but there it is. There was one paper, this is a very nice paper, it was in the Academic Emergency Medicine Journal in 2015. Over 85% of ER physicians surveyed believe that too many diagnostic tests are ordered in their own EDs, and then 97% stated that at least some of the imaging studies they personally order are medically unnecessary. So this is not going to be solved by educating them about appropriateness, because they already know. Other common overuse cases, inpatient morning portables, most of them aren't needed. Almost all outpatient thyroid ultrasound and virtually all requests for outside overreads. We did a fun project where we got everyone to agree, all the ICU services, that a morning portable wasn't an automatic thing that every single ICU patient needed every day. The point of time, this is a sort of a timeline, a run chart of our project, and looking at the volume of morning portables. The main thing they eliminated was sort of batch ordering of an AM morning portable on every patient, at the time of admission for every day in the foreseeable future. We actually reduced the volume of morning portables a little bit through that project. I don't think it lasted. And of course, now we have private companies advertising, get your Ezra full body MR scan, and it only takes an hour and screens for cancer in 13 organs. And these ads sort of appeared around the same time as the California Psychic ads, which offer you the joy of certainty. You may have seen those. They're very funny. The ACR appropriateness criteria are really terrific. I've been involved in helping write some of them, and they are very, very useful. Right now, there's 227 diagnostic imaging and interventional radiology topics with over 1,080 variants. So we've done a lot in this, but it really has had very limited impact. And clinical decision support, which is something that we worked on very hard in past years. I did a project that was funded by the ACR on that, and anyway, it largely failed. The PAMA Act of 2014, you may have heard of, the enforcement or penalty phase has been deferred indefinitely. So we don't have a real handle on this. This was the paper that came out of the project that we did for the ACR, looking at why clinicians order things outside of the evidence-based guidelines, and why they resist clinical decision support. And truthfully, it's because they feel uncomfortable with diagnostic uncertainty, and they're trying to sort of grasp at straws and order more tests and try to get to a higher level of certainty. They do a lot of shotgun imaging. But that number one driver really appears to be a sort of a desire to reduce clinical uncertainty taken to the extreme, and testing for unlikely things. So they're kind of tilting the windmills. This is Picasso's Don Quixote. We're seeing a lot of shotgun imaging done without a clear aim, without a clinical question, without a diagnostic hypothesis. This is in sharp contradistinction to the National Academy of Medicine view of the diagnostic process, where diagnostic testing is only a small part and it comes after all of the other features in the diagnosis development. We're trying to sort of skip all this and just go right to the giant donut of truth, which will hopefully give all the answers. And in fact, increasingly, I'm seeing that our photons are the first things that touch a patient in our emergency room. They go straight from the waiting room and pass through the great donut of truth. And only after the results are available does anyone see the patient. So overutilization, lots of different factors. Patients demand imaging. We have great new technology with higher accuracy, and we're seeing little ditzels and wanting to follow them. The media tells us that the Kardashians are getting their whole body scanned, so why don't you? There's some sort of general biases, like new is better than old, and faster is better, and earlier is better. And there's certainly a component of defensive medicine, fear of being sued, fear of missing things. I think there's been some sort of expansion of disease, and we used to only diagnose large pulmonary embolism because it took a catheter angiogram to diagnose it. I'm kind of dating myself, but now that you can do a CT scan, you can see lots of tiny little ones, and really we don't even know if those are disease. That could just be normal. So anyway, here we are. We have a demand capacity mismatch. It's creating a crisis in radiology because the Great Resignation and other factors have reduced our workforce. Replenishment of workforce is insufficient. Our high clinical volume, it basically now threatens to exceed the collective capacity of the entire specialty. And in many practices, this has driven up RTAT and has created backlogs of unread cases. We've suffered from this at Hershey. So intolerance of uncertainty, a desire for more objective data to justify clinical decisions, decreased clinical assessment skills by the clinicians, a rise of telemedicine, habits and training, defensive medicine. I could go on. Certainly desire to increase efficiency, APPs practicing with less medical knowledge and skill. Honestly, it seems to be a worldwide problem. And some people have cynically said it's because we get paid for doing more, but they have the same exact problem in England, and they're not being paid in the UK for doing more. So this is sort of our current state. And so we have quite a bit of waste. This is a paper that estimated the low value care between 75 and $101 billion. So the financial magnitude of the problem is quite large. And medicine's price tag is really growing quickly relative to GDP. And this kind of puts a target on our back, because even though we're not ordering the studies, we are being paid for them. And CMS is looking at this and saying, well, all we really could do is just slash reimbursement across the board. So I want to just mention this as I get toward the end of my time. This now classic paper by Fryback and Thornbury that was in the Journal of Medical Decision Making back in 1990. And look at the first sentence. It's clear that the appraisal of outcomes of care will have a major impact on medicine in the 1990s. that just did not happen. We don't focus on outcome. We don't answer the question, are patients who are, scanned in this way, do they have better outcomes than other patients? So Fryback and Thornbury gave us this, 6-level scale of the hierarchy of medical efficiency. And we clearly have reached, level 1. We have great technical efficiency. We can resolve all the line pairs, great grayscales. Level 2, diagnostic accuracy efficiency. We can tell normal versus abnormal quite well. Level 3, diagnostic thinking efficiency. If you ask doctors, they mostly feel that imaging is helpful to them. Therapeutic efficiency, it often changes patient management. So we get all the way to level 4 quite nicely. But in terms of patient outcome, and of course, societal efficiency, where does the cost, beat does the benefit exceed the cost? We have not done very well with level 5 or level 6 of the Freiberg and Thornbury model. So what can we do about this? Well, I think we need better outcomes data to evaluate the value of imaging for specific clinical questions. And that will help us, I think, to reduce waste and increase the value of what we do. Number 2, evidence-based guidelines, they need to incorporate individual patient risk factors. Most of what the ACR-AC does is say whether the modality is good for the particular question. Also, they could be hardened to simply say when imaging should not be done, which they rarely, if ever, do. So these are hard things. This is harder than it looks. Don't try that at home. Our top priority is getting a deeper knowledge of patients' clinical outcomes as a result of imaging. Do patients who are scanned, do they have better outcomes than patients who are not scanned? And if so, under what circumstances? And we want to limit utilization and guide utilization, and we're going to need to know how it affects patients and their outcomes. This is our true north. And the late economist Milton Friedman wisely said that the evaluation of a government program must be based on its outcomes, not the good intentions that led to it. And so I think the outcomes of our patients is what has to guide us, not that we can image them better and clearer. So, this is sort of radiology's moonshot. We're kind of at a new inflection point. We need to start shifting our efforts to outcomes. Number 3, I think that we should actually begin to think about whether our role should include being a gatekeeper, as is done in other countries because of our resource limitations. I don't think this is a comfortable idea for most of us. But, for example, an ER doc cannot order an upper and lower GI endoscopy. They can only get a consult, and the GI doc decides that they're going to do endoscopy. But we don't have a radiology consult. We have an imaging order. But the radiologist could be the one to determine whether imaging was needed, and if so, what. And then, of course, the radiologist would have to take full responsibility for their decisions. So that would be a brave new world for us. I think there are some solutions to these problems which exceed our sole reach. Medical education to include resource-limited diagnostic reasoning, trying to teach people to have a greater tolerance for uncertainty and less reliance on testing. Payment reforms that create disincentives to wasteful resource utilization. Tort reform, which Dr. Lex and I have long discussed, and it's just never going to happen in Pennsylvania. And then, of course, trying to temper clinicians' sort of unrealistic or magical expectations regarding the power of imaging to resolve any and all questions, which they have. We could probably train more residents if we could find alternative funding streams to increase the number of slots. Most programs have the capacity in terms of their faculty resources and volume to train more residents than they do, but CMS only funds a few. We could strike maybe a better balance between the general radiologists and subspecialists. Generalists have shorter training, greater versatility. We can try to import qualified radiologists from other countries, English-speaking countries that have similar training to us, streamline those alternate pathways and try to deal with the mismatch by increasing supply. And finally, we can improve radiologists' efficiency, either with better IT or with AI to augment human performance, but that probably won't happen too soon. But I think there may be a future here, and the the rest of this webinar is going to be focusing on that. But this is the problem that we're trying to solve. And of course, there'll be time for questions at the end. So I'm not going to ask for them now. Thanks very much.
Thanks, Dr. Bruno.
I'm trying to stop my screen share. Oh, okay, good.
I think I'll take it over.
Great.
There we go. All right. Hi, everyone. I'm Dr. Benjamin Strong, and thanks as well for the invitation to speak. So I recognize that as a large teleradiology practice, virtual radiologic has a few advantages, but I still think that a lot of the techniques and strategies we've developed can be implemented in smaller practices. So that's what I'm hoping you'll take from this. Certainly, I don't expect you to see to achieve this level of data analysis and forecasting and all the things I'll be showing you. But I think there are points here that you can take and implement in your own practices. So our advantages are that we're very large, that we have a uniform platform, and that generates data that we're then able to analyze. So I decided we're really just going to focus on the first half of these, and I noticed a lot of our submitted questions actually address issues on the other list I have there. So hopefully we will get to those. I'd like to start with forecasting and performance analysis, and I think this is really critical. If there's one takeaway from this, it's find some way to know what is coming down the pike, what you'll be dealing with in any given night or week or month or year. And I just think that's absolutely critical. Then come up with staffing strategies that allow you to match your capacity to your anticipated volume. So I see a lot of radiology practices that say, well, yeah, we have staffing solutions. We make sure there's a guy in that chair 24 hours a day. And that's not what I'm talking about. Actually trying to match your level of staffing and the specific capacity it's capable of to the known or expected influx of volume. That's how you can succeed at this. So we do long-term forecasting. You can see we actually do pretty well. And I will tell you, this is not a small thing. So you can see the blue line is our forecast and the green line is the actual volume that we saw. And we usually have upper and lower bounds that we expect these to fall within. This is not easy. In the last 15 years or so that we've been dealing with this at a large scale, we've brought in 3 different consultancies and all of them failed. One even had the arrogant name of Gordian knot, claiming to be able to solve or untie any problem. And they all walked away completely having failed. We have one guy who we brought up in our computer software engineering systems who had a love for this sort of thing. And he took it over and he's the one that ultimately succeeded. So no fancy degree, but just steeped in VRAD knowledge, basically. We track missed capacity. So we don't just guess how many studies we'll be getting. We also calculate the capacity that we expect from every radiologist for every hour of the coming 18 months. But then we have to tailor that a bit with an expectation that in any given night, we'll have people with illnesses, family emergencies, or internet outages. And so we track that as well. And you can see on the most recent night I'd done here, we had 3 radiologists who were unable to join, and the capacity that we lost was 92 studies. So we try to factor these trends in as well. Taking that data, your supply and demand, and then translating that into an anticipated average turnaround time was a serious challenge, but we have gotten there, and it's mostly through just looking through historical data and matching future scenarios to past ones. So overlapping shifts is a big thing. And this is actually the most important chart. I think it really shows our forecasting and then our retrospective that our data analytics capability enables. So for any given hour of the coming 18 months, we have an expected forecasted demand, which is the orange bar, and a calculated radiologist capacity. And for that, we don't just count a butt in the chair as able to read this many studies. What we actually do is take the trailing 90-day average that each radiologist has done individually in that hour of their shift, and we add those numbers up for a very realistic anticipation of what capacity we can bring to the field. So you can see then what we do is we go back with retrospective data after the night is over. We publish these every morning at 8 a.m. And if you track the orange line, that's the actual demand that we received. And if you track the green line, that's the actual capacity that we achieved. So the perfect night would have the green line skimming across the tops of the green columns and the orange line across the tops of the orange columns. So you can see right here in this segment, this shows very nicely how we can track this and then how we respond. You can see we had a run of a few hours where the orange line, the demand line, was above the capacity line. And ultimately that will pile up and create an increase in the turnaround time line. So you can see as these lines separated, this turnaround time started to climb. And so we put this little icon in for when we call our Delta Force. That's our emergency response team that hops on for bonus pay. And you can see the effect that that will have on turnaround times. Just to show you how we generally schedule, we actually schedule up to about 90% of our expected needed capacity in the long term, because we know we have radiologists who will want to schedule extra shifts, who will want to pay back hours that they have missed, those sorts of things. And so we leave a little room for those people to be slotted in. So you can see we generally schedule about 80% all told. About another 10% are people doing extra shifts or payback shifts. We also have holiday shifts and flex shifts, which are required extra shifts. And so those are sprinkled throughout as we come up to any given day and spot specific deficits that we need to cover. And then lastly is the in-the-moment stuff. We encourage our radiologists to get on when they have extra time. And we have the Delta Force alerts that I mentioned earlier, where we pay a bonus for people that get on. And you can see that's often worth more than 10% of our capacity. We do track the Delta Force activations, as we call them. This was the 14 days over our holiday season just recently. And you can see during busy times, we can call the Delta Force fairly frequently. You can't obviously do this every night. Eventually, the responses will wane. But as you can see, we had with one activation here most recently, 27 people signed on, 9 people extended their shifts for a total of 36 radiologists who read 597 studies. So we tell people that are on our Delta Force that we will alert them by text. It's completely voluntary whether or not they actually get online when the alert goes out. And they're able to stay on for as long as they want. If they want to get on and read one study, well, that will help. If they want to get on and read for a few hours, we'll pay them the bonus rate until they're tired. Compensation incentives are very helpful, and we have an advantage here in that we are compensated on an entirely productivity-based scale. So we did an experiment this summer. Things were getting out of control. By the way, I will be citing work unit values on a few slides. Unfortunately, we have our own work unit schedule that's based on the average read times for every different procedure. So they don't track immediately or directly to CMS RVUs. But as you can see, our turnaround times were unacceptably high in May and June. And we finally said we've got to do something. So I like to joke that I managed to spend $1 million while the CFO was on a fishing trip. That actually is true. It cost us $1 million to increase the pay for the specific pain period that we identified through our analytics. Our folks came back to us and said, if you get rid of the 1 a.m. to 5 a.m. bump, it will fix the turnaround time problem for every 24-hour cycle. And so we actually made a significant increase in the work unit values during July and August. And it was in an effort to see, this is the green line, what the effect would be on turnaround times. And then as we came out of the summer in September, which is over here, the blue line, we brought it halfway back to normal to see, was it in fact a linear relationship? And it actually is pretty close to a linear relationship. The more you pay, the more people will get on and the faster they will read. Generally speaking, when people are working for a bonus rate, they will read about 10 to 15% faster during that time when they're paid on a per study basis. So that experiment led, and we were already working towards this, but I would have to say our summer experiment last year accentuated the step-ups that we created for our pay scale. We call this our Uberization of pay. The simple fact is, if a given slot or hour or even procedure for that matter is less desirable to radiologists, if you pay more, they will do it uncomplainingly. So as you can see, we have scaled up the pay that we give for every one of these segments during the 24-hour cycle. And then we step this up actually further for different seasonal fluctuations. A few operational points to make. One is study distribution. So on the left, you can see of all studies, what rate of subspecialty matching we achieve. And remember, we are in the emergency teleradiology world, so it's not an absolute goal of ours to match all studies to a specialty. Of note, we have separated the simple from the complex studies, and we make a greater effort at matching complex studies to specialties because our QA assessment has shown that in the emergency teleradiology world, there isn't very much difference in simple studies, say, for instance, a non-contrast head CT ordered emergently. There is a difference of less than one error, one major miss per 10,000 studies between generalists and neuroradiologists on the non-contrast head CT. But that ratio shifts, that difference in QA in major misses does shift when you get into the more sophisticated imaging, in this case, brain MRI. So you can see we make a better effort at matching those to subspecialists. But what we do is we have created a way to essentially dial up or down our efforts at specialty matching based on the overall turnaround times. So you can see the lower our average turnaround times are, the more effort we make to specialty match studies. And as turnaround times deteriorate, we make less effort. That increases the pool of radiologists to which any given study can be distributed. And these are our specific neuromatch efforts, basically the same data. And you can see again that we're able to dial up or down our specialty matching efforts based on the turnaround times we're experiencing. So we have a number of ways to prioritize studies. So up front, when a study comes in, you're going to want to sort them out for the ones most likely to have a critical finding. Those are obviously the ones you want to, the needles you want to pick from the haystack and treat differently if it's at all possible. So we have procedure-based prioritization, which is based on our assessment using natural language processing of the occurrence of critical findings in a given procedure. And we took our top 20 procedures and said, we are going to be expediting those over the other procedures. And you've got to be very selective. We went a little crazy with this initially. The first time we rolled it out, we had added too many procedures and it didn't seem to have much effect. But with just our top 20 procedure names out of the total of 1,000 CPT codes, right, we really were able to move the needle. So you read this as at 60-minute turnaround times, right? An average study will come in and it'll be a 60-minute turnaround time. So when our average is 60 minutes, Those that have been expedited by virtue of this prioritization scheme, they'll come in closer to 45 minutes. We also have artificial intelligence algorithms that identify specific severe pathologies that we have identified are either commonly missed or expensive when missed. Those AI algorithms then are tied to prioritization on the work list. And you can see an AI prioritized study at average turnaround time of 60 minutes comes in just around 25 minutes instead of 60 minutes. And then lastly, we have specific designation of trauma and stroke studies. And that is present all the time if the technologist submitting the study designates a study as a stroke or trauma. We have a very consistent about 12-minute turnaround time on those. So knowing up front which studies have issues or could have issues is a very helpful way to prioritize your work list. This is just an interesting little thing that we did. We actually detect critical findings in the radiologist reports, and we automate the calls to facilities. And over the last year, we really expanded the critical findings that we can identify that way. And as you can see, we had a significant increase in the number of critical findings that were in fact called. So the last thing I'd like to hit on is I saw a lot of questions about workflow, AI, things of that nature. And I thought I'd pull this out because it makes a great point. So these are our average, again, these are VRAD work units. We went from 6.5 to 9.6 as our average work units per hour. Just as an overall practice over the course of the last 11 years. And this was through all kinds of technology development, increased RAD efficiencies, reporting techniques, PACS development, everything factored in. And the thing I like to point out is I see practices chasing a magic bullet. Ooh, this is going to be the thing that fixes our turnaround time problem, or that finally makes our radiologists efficient. It doesn't really work that way. What you have to do is develop a culture of radiologists that are embracing these efficiencies. It doesn't drop in one big lump, right? Where all of a sudden you see, aha, that feature did this for us, right? It really doesn't work that way. It's a steady and continuous increase over a long period of time as you develop features that augment one another, that create greater downstream benefits and enable more development down the road. The one bump that you do see here, which is kind of funny, is that was during COVID. And so because we all had a little extra time and low volumes, we actually embarked on a campaign to aggressively train our radiologists. And that was radiologist training on our existing system that really made the only significant detectable rise in this chart. So, all right, that's all my time, and I'll hand things over to Dr. Ortiz, and hopefully we'll address some of these other issues during the Q&A.
Thank you, Dr. Strong. All right. So I am going to be talking from a smaller private practice perspective. So I serve on the board of my practice, I handle sort of operation for the practice, and my focus is really going to be on strategic growth. A little bit of a background. So I've been in our practice for almost 5 years now, and I think I was around the 19th or 20th person radiologist to join the practice, and now we'll be 43 by the summer. So we've more than doubled in size in the span of about 5 years, and I'm going to kind of give you a little insight into how we handled it. So first of all, I'm going to talk about organic growth management, talk about how to assess new opportunities, look at current contracts versus new opportunities, look at some nimble scheduling, and then go over some case studies. So with regard to managing organic growth, a few things that are important is to understand the hospitals and outpatient imaging centers to understand what their new equipment investments are ahead of time. So usually I meet with our hospital partners and outpatient imaging partners on a monthly or quarterly basis. And one of the key parts of the conversation is if they're bringing a new scanner online, new equipment, and things like that. And that lets me know ahead of time if I need to increase staffing, number of staff during the day. Understanding new ER beds, hospital bed counts, to figure out inpatient growth, and ER, which are going to be more aggressive on the turnaround time front. Also, with regard to the new equipment, one of the things that happened last year was we were under the impression that a new outpatient scanner was being placed, but upon further discussion, found out that they were going to be using that scanner also for ER at a certain time point. So that helped us kind of have an understanding that they were going to have extra capacity for CT for additional hours. And I think really the key to managing the organic growth is particularly with a hospital-based practice is to be involved in the hospital leadership. By doing so, not only are you aware of capital investments and hospital bed count and things like that, but you can really be ingrained in the hospital culture and help manage inappropriate inpatient volume, which was discussed earlier, and hopefully drive some of that inpatient volume towards the outpatient setting. So I'm going to go a little bit over how to evaluate current contracts for new opportunities. So one of the key points I think is to use your billing data and try to get an overall global idea of the dollars per RVU that you're bringing in holistically as a practice. That kind of helps set your baseline. Next, and I'm going to show you how we do this in a very very easy format. I did not have $1 million budget to pay consultants to figure this type of stuff out. It took me a few hours of YouTube and playing around on Excel to kind of get this situated. And I can show you, I'm going to show you here in a little bit how I did so. And by understanding sort of the hour volume, you can really adjust creatively, sort of shift hours, and then also sort of responsibility for individual shifts. And once you have a baseline for your current status for your practice as sort of a dollar per RVU and sort of the volume data, you can really bring in new hospital data and evaluate new projects, project new opportunities, and figure out if they'll fit into your sort of scheduling template or if you have the capacity to take on that business. One of the things that has helped us in our growth the most is keeping nimble. And I'm going to kind of go over a few things that I think are important in sort of maintaining that nimbleness. So especially out in the community practice where I practice, it's very encouraged to keep as broad of a skill set as possible. And what that is defined for your practice really depends on your particular culture. It can range anywhere from 100% full general practice with sort of a phone a friend culture to a more subspecialized culture, but encompassing 2 or 3 subspecialties per person or something in between. I think that is particularly key to allow for the flexibility, particularly in after hours to maintain sort of an efficient staffing model. So again, develop that culture of a general practice. And when onboarding new hires, I think it's important to pass down that culture to the new hires. You know, for everyone, it's a mixed bag of what type of people come into the practice. And I think it's important, especially in the first few months, to kind of gauge what sort of studies the new people are preferentially picking and things like that, and notice any particular trends. For instance, if someone's not picking up a particular study that they're going to need to be able to do to take call and things like that, I think it's important to kind of address that early on, kind of acknowledge the fact that you notice that they may be avoiding the particular studies, and then sort of offer counsel and sort of coach them up to get that comfort level back to those studies, since we are all trained and passed boards for the practice of general radiology. So I think another important thing about keeping nimble is to figure out how you do your schedule. So for us, I make the call schedule and the weekend schedule and vacation schedule on a quarterly basis. Usually in the middle month of a quarter, I will send out, calculate how many vacation days we'll get for the subsequent quarter, and then I'll figure that out there. But it is important to be able to plan trips ahead of time. So what we do is we'll allocate a certain number of pre-pick weeks that we can choose a year in advance. That way people can have some very specific weeks that they want ahead of time. So it kind of balances the need for advanced planning for important events in people's lives, but also allows a nimble practice in case you bring in new business or have some organic growth going on, or if someone goes out on medical leave or things like that. It helps address those variations that are hard to predict in the future. Another thing that we do to help build in flexibility is we have a couple of people or a couple slots on the schedule every day of the week that we just call practice management, but it's sort of a flex day off. And that helps address any times where someone needs to call out or things like that. Another thing to help keep nimble and be most efficient is if you can set up a system in which you're able to access all your hospital systems or multiple hospital systems or multiple imaging centers from all the stations. So usually in every single one of our hospitals, we put in our own workstation with our own internet line separate from the hospital. We pay for all of it. All we ask for is the space. And that helps us to be able to access other systems. For instance, if one system's caught up, we're able to help out on another. And I think another piece that is important is, I think Dr. Strong mentioned, having staggered hours is very helpful. And the more you're able to push the workforce towards a remote setting, the easier it is to deal with these staggered hours. So over time, we've pretty much pulled all our on-site requirements to just sort of during the weekday daytimes, and we've eliminated all our on-site time, at least on the diagnostic side, for the evenings and weekends. And that really makes us nimble in adjusting schedule hours. Let's see it ending. Yes. Oh, and another thing that's been critically helpful, particularly in helping with turnaround times, is we a few years ago made the decision to have 24/7 sort of read room assistants remotely in-house that knew our physicians, knew our hospital partners, and really developed that relationship as a intermediary between us to help call results, get in contact with physicians if we need them. That's really helped our efficiency and helped us tackle larger volumes over time. Let's see here. All right, so I'm going to go over a couple of case studies. So first of all, I'll show you just how we've handled after hours and weekend volume. I'll give you an example of what we do. So one of our radiologists was key in sort of building a home brew RVU database. And so I'm able to pull hourly RVUs from that database and kind of play with Excel. There are much more sophisticated ways of doing it through various tools. Like I said, I didn't have any background or expertise in this. I kind of watched a few YouTube videos and figured out how to play with pivot tables and things like that. So here's just an example of an audit that I did from August to September. Here are the columns are the hour codes, 0 to 23, the dates, and then sort of the number of RVUs in that particular hour. Just summed them up here, total RVUs over over an hour. And then down here, I listed out all of our shifts, put a 1 in place for every time that there's someone working that hour on that shift. Figured out the number of FTEs per hour, did a division thing to figure out the number of RVUs per FTE, did some color coding, conditions-based color coding. Again, just one YouTube video helped me figure that out. And with this simple tool, I'm able to kind of highlight a shift and see what would impact how moving particular shift left or right, an hour early, hour later, would do to the schedule. So I just set a threshold for comfort level for our practice as far as RVUs per hour. And then this is really how I do my quarterly audits. I just pull the data every quarter, copy and paste it into this Excel sheet, and I'm able to play. So every few months, a lot of times I'll end up tweaking this. And that's just how we've been able to get by to manage increased growth. So case study number 2, I'll give you an example of a hospital we ended up not partnering with for various reasons, but I'll kind of give you an example of how I evaluated that practice to figure if we could incorporate it into our practice. So and anytime we get a new hospital partner that wants us to read for them, I ask their team to pull an audit report for their imaging volume. I've anonymized this one, and every time I do this, it's a completely different format, completely different columns and things like that. But again, after a few YouTube videos, you figure out how you can create formulas to parse time elements, days of the week, modalities, things like that. I created just a copy and paste of the parsed out data. And then paste it into a new Excel sheet, created a pivot table of the data using these parameters here. And then I was able to pull, copy and paste from each day of the week, the data from that pivot table to figure out the number of average CTs, average fluoro studies, mammo, varies by modality, and figure out just using sort of the number of hours I pulled here, as you can see, from overnight up until 4 p.m., the number of CTs to figure out how many imaging studies would happen during a day shift, happen during an evening shift, just to figure out what the capacity would be for those days for the weeks. And interestingly, I have noticed that a lot of hospitals have variability between the days, and sometimes it's because particular clinic, from an ortho clinic or something like that, has x-rays on a particular day. So there's some intraday variability that you can highlight if you kind of don't take it as an aggregate. So between these two things, that's kind of how we evaluate new hospitals, how I look at our hourly, how I look at our evening and weekend volumes and try to tweak the schedule. And then one other thing that I think is helpful, if you pair the two, I'll give you an example of that. I think a year or two ago, I did an audit of an urgent care system that we had been partnering with, realized that 70% of their volume was after hours and evening, which was a pain point at the time. We had a new hospital that was looking for us to read for them. So I was able to use both the data from the new hospital, the data from the urgent care system, paired that with our dollars per RVU from the two options, and we made the strategic decision to part ways with urgent care and pick up the new hospital opportunity. And using very simple tools with Excel, we're able to accomplish that. So main takeaways: look ahead by staying engaged with your hospital partners, look back, frequently audit, keep nimble so you can make changes when you notice particular pain points or and to be able to address new opportunities. and then weigh those new opportunities against your current practice setup. And that is all. Thank you. I think we got, yep, Dr. Galante is next.
Okay. Thank you, everyone. I'm Dr. Nick Galante. I am with Radiology Associates of North Texas, which is the largest physician-owned private practice in the U.S. We're based out of Dallas, Fort Worth. We are about 300 or so radiologists, and we do both our own internal teleradiology for after-hours work and also our boots on the ground for the vast majority of the DFW Metroplex. So I'm going to touch on something or some of the topics that all of my co-presenters have already touched on, and also try to provide a glimpse forward into the future. So I will touch on non-interpretive artificial intelligence, a universal work list, and distributed workflow to achieve what I preach in my own group as a flow state, and even briefly touch on virtual and augmented reality. So as previously alluded to, this is a live look at the ordering providers these days. It just doesn't stop. And this is a live look of me, how it started and how it's going. I started my residency in 2010, and that was right about when you can see the tsunami, the wave from the shore. And then when I finished, the wave had started to crash. And, you know, I recognize that some of us choose radiology because it is a quote unquote lifestyle specialty. And I don't think it will ever return to that in the traditional sense of the phrase. I think that it might be a controllable lifestyle, but I think the days of a relaxed workday are behind us. And so I preach to everyone at Radiology Associates of North Texas, or RANT, that what I want is a better life for everyone. I want us to all be in a flow state, and that means something different for everyone. But ultimately, the idea is that you are just in the groove at work. You are neither so bored, which I recognize is exceedingly rare these days, but you're neither so bored that you're checking your watch, waiting for the workday to end, or you're so throttled and stressed and overworked that you're checking your watch saying, when is this torture going to end? I want everyone to just pass through their workday in as much of a natural setting as possible, whatever that means for them. But the problem is our current solutions are limited, right? And I touch a lot on the kind of tension between linearity and exponentiality. And I know that we've thrown some graphs up in earlier in this presentation about, you know, image utilization and, you know, exponential increases. And that's truly what's happening. But our solutions are very limited, right? It's hire more radiologists and read faster, and maybe we can sprinkle some tech on top. But that is going to reach a kind of event horizon beyond which you're not going to be able to escape, right? And this was something that was talked about maybe in the previous 5 to 7 years. But we're seeing groups reach this inflection point and surpass this inflection point, right? And turnaround times are getting measured in sometimes days to weeks as opposed to hours. Contracts are being terminated because of it. It's affecting patient care, right? So the idea, though, is that seeing this meteor come in, we need to actually fight fire with fire. And we need to take our linear solutions curve and at a minimum steepen it, but hopefully start to bend it and apply some exponentiality to our own solutions, right? And AI is really starting to afford us some of those opportunities. Now, as was previously alluded to, I think that is in the midterm future. It is not here yet. It is starting to arrive, but the next, and it's hard to say exactly how long, but I would say on average 5 years, maybe a little less, maybe a little more. Those 5 years are still going to be kind of rough. They're going to be kind of choppy. I tell everyone at RANT, find something that's bolted to the ground and hold on to it. But ultimately, with, you know, successful deployment of AI solutions, the goal is that you will be able to scale knowledge work and have exponentiality in your ability to, you know, tackle cases with increased productivity and efficiency, well, not only not sacrificing quality, but even increasing quality, right? Because ultimately, patient care is paramount. Now, it's a very crowded space. everything from small startup companies to large apex predators like Google, Stability AI, so on and so forth. So where do you start here? For the longest time, people thought that pixel analysis or computer vision was going to be the way of the future, right? That something was actually going to interpret the images, generate a report for you, and you were just going to sign off on it. But with the advent of generative AI, which came along with ChatGPT about a year and a half ago now, the shift to non-interpretive algorithms really took the forefront. And I think that those are much more immediately impactful and deployable to practices. Computer vision is still a ways away, and it comes with its own bag of worms, which is that of who watches the watchers, who are the regulators, who are the ultimate arbiters of truth, and so on and so forth. So where I think we can focus currently is on the non-interpretive algorithms. And these are generalizations, but AI and machine learning, intuitive tech, natural language processing, and large language models, generative AI, and then also areas like workflow optimization, worklist optimization, workflow cadence, and forecasting, which have previously been alluded to, a distributed and decentralized radiology network, or sometimes network state, as I call it, to borrow a term from Balaji Srinivasan, standardizing data, right, in a group with the size and complexity of ours. We are constantly struggling with, disparate data from different sites, and even streamlining quality metrics and MIPS, right? So where to start, right? Well, in the non-interpretive space, but let's look at the current tech stack for most groups. This is what ours looks like. And typically you have PACS, a voice recognition, a work list, which may or may not be part of your PACS. Our work list is one that we developed in-house because the solutions out there were not meeting our needs. And then you might have some AI cream on top of all of that. But that's very horizontally integrated. And the first step is, if possible, and I recognize it's very difficult, but try to get more vertically integrated. There's a reason why an iPhone works better than an Android. Sorry, Android people, but it's very tightly controlled and vertically integrated. So if you can integrate your tech stack into one vendor or fewer vendors, I find that decreases a lot of friction. Now, Rad AI is a company that we've partnered with at Rant to in part co-commercialize the work list that we developed. But they bring a generative AI component to reporting that they're starting to roll out that we've been fortunate to be beta testers of at Rant, and it is truly amazing. And this gets back to that concept of exponentiality and scaling knowledge work. Because for the first time, you can actually start to increase your productivity in a nonlinear way. And that's through generative AI and a chatbot, which I'm kind of emphasizing here. So if you wanted to use this as you would normal voice recognition software, which is in a fast, stable, accurate way, recognizing the words that you say and putting them on the screen, great. But if you want to use it for something more, you can. And increasingly, we're dealing with large data sets and what I call the radiome as kind of analogous to the genome. And to be able to search prior reports with your voice, or in a very creative way, generate a report very quickly and leverage large language models for that, that's awesome. And that's what we've started to do here at Radiology Associates. So hopefully this video comes through on the next screen. It's going to be kind of boring, but it's me dictating, a kind of neat MSK case that has a pivot shift injury and an ACL tear. I'm using a bunch of macros. I'm doing it through the chatbot, and I'm using that to retrospectively fill my report and then generate an impression for me. That triggers the generative AI component. All while keeping your eyes on the study, ideally. Done with your findings, click a button. Well, you can still be looking at the images and taking advantage of almost being in two places at once, generating your findings, generating your impression. And there you have it. Although I probably would have deleted impression 0.6. So moving on to other solutions, universal work lists to create a distributed and decentralized radiology network or network state. I said we were using a third-party solution for our work list, and it just wasn't meeting our needs. And necessity being the mother of innovation, we developed our own to handle the complex DICOM routing and just sheer number of different healthcare systems and outpatient imaging centers we work with at Radiology Associates of North Texas. And that broadened our horizon because whereas a work list, particularly one associated with the PACS, has one function, we imagine a work list as an operating system or utility tool or Swiss Army knife that did not just present the studies, but helped you manage workflow and distribute that workflow, had messaging integrated into it, had scheduling and forecasting components into it, and even had peer learning built into it. And you know, when I'm overwhelmed at work, I'm trying to channel my inner stoic, right? And what does a work list have to do with stoicism? Well, it has to do with, what you can control, right? We can forecast based on secular and cyclical trends what we think the workflow is going to be, but ultimately we do not control, unless we go to an outpatient imaging center, we do not control how the patients come into the emergency department, how the ordering providers order their inpatient studies, right? What we can control, what is under our control, is the deployment of our workforce, how and when we schedule physicians, and doing it in creative staggered ways and even discontinuous work days, and also the distribution of that work amongst our physicians, right? So how are we divvying up the work? So that takes us to the concept of, the legacy system to a unified workflow system, or the nation state to the network state. And whereas it used to be, and someone alluded to earlier, we have a workflow solution, we put a butt in the chair during working hours. That's really like the nation state. That is just kind of the old school Game of Thrones system. Whereas the decentralized model is, you might be sitting at one spot. This is the primary hospital I work at, but I'm not actually working there. I'm reading some of the studies on that list, but I'm really reading in a cloud-like environment. And I'm doing that in an optimized way that lets me achieve that flow state, and also do it in a way that's better for patient care, right? Because I shouldn't be reading, as a musculoskeletal trained radiologist, I probably should not be reading the, follow-up radiation and resection brain tumor studies. It gets to the concept of what can I read and should I read, and how do you distribute that to decentralized workflow? As alluded to by some of the earlier presenters, a lot of this is based around group culture, right? And creating a good group culture, and also recruiting for a good group culture. But ultimately, I look at these as Venn diagrams, and you want to optimize overlap of that for each individual radiologist in your practice. And while this diagram here is very intuitive to any machine learning or AI, computer software developer, it's not very intuitive to radiologists. We think we have the answers. We think we know how to optimize the overlap of those Venn diagrams. And that's what traditional programming is. And we say, well, this is how we think you should read. And this is what we believe we are optimizing for based on that algorithm. But ultimately, there are larger trends and patterns there that are beyond our ability to recognize, that require artificial intelligence to detect. We are not as smart as we think we are. Ultimately, what you hope to do, and what we're attempting to do by weaving artificial intelligence into our in-house developed work list, is say, well, let's start with the answers. Let's start with what we're trying to optimize for, right? We're trying to optimize for turnaround times within these parameters for outpatient imaging versus inpatient imaging. We're trying to optimize for 24/7 subspecialty reads. We're trying to optimize for a certain productivity metric per unit time per radiologist. And also we're trying to optimize for radiologist satisfaction, right? My optimal algorithm might be 2 normal studies, followed by 3 ICU chest plain films, followed by an MSK exam that I really like, followed by a nice, easy negative DVT study. But those rules are different for everyone. Ultimately, you put in what you're trying to optimize for, through artificial intelligence, are able to glean the rules that are beyond the purview of your simple human vision. And so that has the effect of taking credential-driven workflow, which is classically very uneven, and smoothing it out across all the large networks that you read for. Taking subspecialty-driven workflow, which is classically very uneven. You have to call someone, or you have to ask your maybe teleradiology assistants, is there an MSK reader for this? Is there a neuro reader for this? Smooths all that out, lets you achieve that flow state. And so you're actually able to optimize overlap of what you can and should read on a radiologist by radiologist basis in very complex ways based on who is working that day and who is not, right? And you ultimately leverage the size of your practice. And I recognize we're very fortunate in radiology associates to have a large practice, but you leverage that. And the value of your network is defined by Metcalfe's law. And you can start to achieve exponentiality and true scalability of knowledge work in a way that allows you to start to tackle this tsunami of workflow. And that's what we've started to achieve here at Rand. I look at it as a hive mind or a network state of distributed and decentralized radiologists throughout the state of Texas. And ultimately, you're getting back to that flow state. Now, there's a lot of benefits of this decentralized workflow, 24/7, so specialty reads, robust credentialing coverage and turnaround times, workload balancing, higher radiologist impact, happier contractors, your hospital and outpatient imaging partners, and ultimately, and most importantly, better quality of patient care. The last thing I'll touch on here is discontinuous and staggered work days as afforded by AR and VR, right? And so I think back to that tech stack, right? That's your work list, apps, voice recognition. That requires a workstation, right? You have to be sitting somewhere. And if you're lucky, it's a room with windows and a stand-up desk. But oftentimes it's not. But if you can put that all in one spot through augmented or virtual reality headsets, you can start to really take advantage of this network effect because you can call people in as needed. I find that people are able to read in short bursts, kind of like high intensity interval training. And they're able to be productive in short bursts as long as they know that there's a stop point. You just have to be very focused and manage your focus and not manage your time for an hour or two, which is typically the battery life of many of these headsets anyway. And so this is kind of like being a mercenary and being able to call people up, like in the Bourne Identity, and say, as alluded to earlier, you can do this with, you know, various kind of pay-per exam or Uberization monetary incentives, but you call people up like mercenaries. Now, it doesn't quite look like Jason Bourne. This is what it looks like. This is me and my now 16-month-old. She does not get what this thing is, but it looks something like this. And this is Visage Ease for Visage Pro in my home office. It's going to look choppy because the video just doesn't translate well across Zoom. But, you know, you're in this virtual world in your office. You only have the apps open that you need for work and everything else is tuned out, but you're doing that in a short burst, right? And so again, managing focus and not time, you're able to work for a couple hours and then do something else, work for a couple hours and then do something else. And ultimately you can extract a lot of productivity and quality while doing this, and also leveraging all the other non-interpretive AI solutions, potential computer algorithms that are coming down the pike, and distributed and decentralized workflow at the same time. So these are all things that make me excited about the future of the specialty. Now, my take home is that there is no way out. Yes, we can educate clinicians about ordering patterns. Yes, we can, you know, go to accountability care models and give the ordering providers a smaller piece of the pie, right? Yes, we can try to build positive culture and do forecasting and try to optimize workflow, but ultimately, this is not going anywhere, right? Image utilization, you can't, in my opinion, you can't unbake that cake. And then you just add demographics and the baby boomers, which have just started to retire, and you add the whole wellness cohort and the, you know, full body MRIs for the healthy folks. And the only way out is through. The only way out, I'm convinced, is to leverage all of these techniques and achieve some degree of exponentiality in your own workflow, and also do that while improving quality and patient care. So my takeaways would be that then the only way out is through. Use this opportunity to get creative with solutions, because you have some leeway. You can say, hey, we can't provide on-site coverage during or 5 days a week. We'll give you 3 days a week. And then you have a radiologist that's, you know, remote, and then you can start to stagger shifts, be flexible and lean into the new technology, because as someone who is the CMIO for a very large private practice and gets approached by a lot of startups, this is not going anywhere. I feel like we're back when I was in medical school, and all the drug reps would solicit you. And I never thought that would happen in radiology, but it's starting to happen because this is such a crowded space. Embrace the new roles that this technology is going to afford us in expanding our practice patterns into both triage and management, and even capturing some of the revenue cycle for those, which wouldn't that be great? And know that the near-ish future is bright. But again, this is a lot of these are at the bleeding edge, and we're not quite there yet. And I still think the next 5 years plus or minus are going to be a little choppy. So that is all I have, and I thank everyone for their time and for listening to me.
All right. Well, I want to thank Dr. Galante. I want to thank all the faculty. Can you all unmute and put your video back on? Tremendous jobs by everyone. And ask Dr. Nathan to come on as well. And we're going to go ahead. We've run a bit over. We can probably go a bit past 8:30, but we won't keep people more than about 5 minutes or so late. But we have some tremendous questions. Dr. Nathan and I can take turns with some of the questions, but I'm going to start with one which Dr. Strong answered, but might want to come back to him. But certainly I want to hear from other people. How do you prioritize studies to be read in order to decrease turnaround time? And how do you get referring providers to escalate studies appropriately? And just want to hear some other perspectives on this. Dr. Strong gave a great answer to this question. But how do you do this? Because this is one of the commonest things that I hear when we talk about turnaround time, which is the wrong things are getting turned around at the wrong times.
Right. Well, I'll just add to what I said previously, that we have a number of strategies. I think looking at those studies that have a known higher incidence of critical findings, those that are identified by AI algorithms, and those known to be time sensitive, trauma and stroke. Those are the ones you really want to prioritize. In terms of discouraging inappropriate ordering, the one thing that I have seen really move the needle is just putting checks, automated stops around the ordering of a study that is inappropriate for a specific urgency. And so a good example for that is we just put blocks in our system where you cannot order an X-ray as a trauma study, right? We reserve that just for CT scans. And we had plenty of people say, well, if I just click trauma, it'll be expedited. And so they would do it on a chest X-ray or a foot film or whatever they felt they could justify. And so putting those kind of automated restrictions around specific procedures that are inappropriate for heightened urgency is one thing we saw actually really help.
Okay, thanks. Maybe I'll turn it over to Dr. Nathan for the next question.
Sure. So my question is, how do you balance radiologist wellness with efficiency, productivity, and sustained effort, particularly in the face of current workflow shortages and generational differences and expectations at the workplace? Anyone want to take this one?
I'll just say that's very hard, and I don't think any of us are doing a great job. But I think it's a great question, and the fact that people are thinking along these lines means that we're going to do better than if we didn't think about them. I think we have to be very flexible and creative, allow hybrid kind of work where some people are working at least part of the time off-site. I think that shifting toward slightly lower degree of subspecialization to allow people to have more flexibility in scheduling, I think, is also very helpful. Those of you in the private sector don't feel that subspecialty push to the same degree that we do in academics, but I think we actually need to pull back a little bit from that. And we've developed an entire division of community radiologists who some of them are specially trained, but all function more or less as generalists. And that's really sort of helped us a lot with that, with optimizing our capacity and also keeping the work-life balance. The younger generation really values that a lot more than us geezers do, or did.
I think that flexibility in scheduling is key, and as broad of a skill set as you can to kind of interchange people helps. For me, making the schedule, it's sort of harnessing the benefit of being a smaller practice is I know everyone in my practice individually. Making the schedule, I kind of learn everyone's life stories. I get to know, when people have kids' soccer games and things like that. So I'm very open with everyone. And when I make the schedule, I'm very open about saying, hey, if falls come in and you have kids' games on these times, then I'll use our scheduling app, Qgenda, and I'll adjust the rules so that they can make those events that are important to them. The other thing is, there are certain cohort of our practice that just want to read fast, not get interrupted, work from home. I will schedule them towards more the off-hour evening shifts, whereas the people that kind of want to engage in hospital administration and that front, and then also that might have younger kids that want their evenings free, but have to drive. So everyone, you kind of figure out what people's currencies are for their life and what's important to them, and they're willing to make sacrifices on another front in order to get what's important for them.
I'll reiterate that. I agree with the flexibility from a scheduling standpoint, but also from the hour-to-hour workflow demand standpoint. We don't have a minimum reading rate, something that we're, enabled to do because of the size of the practice, but and we have all this data, right? I tell radiologists all the time, it's true that we do know exactly how many studies you read every hour you work. We know the modality breakdown, the body part breakdown. We actually know when their mouse hasn't moved for 5 minutes, and we suspend distributions to their work list when that happens. But that's not to scare people. I always tell them this is not a big brother situation. We're not doing that in order to shoehorn everyone into what we consider to be the one acceptable workflow and productivity rate. In fact, all we do that for is to measure what you do and then plan for that in the future. And it's a very different approach to things that has enabled us to really dial in a workflow, work-life balance for each radiologist. Being able to choose the rate at which you read in any given hour, night, week, month, year, for that matter, is extremely helpful. Then everyone is their own boss, and they don't tend to overtax themselves.
And I'll just add, given our size, we have basically every age cohort in the demographic range, and we've toyed around with the idea of what we call shifts in service to the group, right? Like the inpatient fluorosono shift, which, backing up, we do have average productivity requirements. You don't have to hit them every day. You just have to hit them over an average of a month or rolling 3-month basis. But historically, the inpatient X-ray and fluoro shifts or lower RVU work, and you have a harder time hitting your threshold, we adjust the threshold for that shift to be lower, and at the same time, we say that these are basically shifts in service to rant. There's not a lot of people that would voluntarily want to do them, but if you have someone that's, say, toward the later stages of their career, they're going part-time, they'll say, I'll do that, and as long as you suspend the productivity requirements, I'll take this less desirable shift with those trade-offs.
Okay, great. I'm going to take the next question. I'm actually going to combine a couple of questions that are on the list. But other than doing procedures, I'm paraphrasing here, how are any of you, if so, integrating non-physician advanced practitioners, RAs, et cetera, in a physician-led model? And how are you using them to handle some of these issues of turnaround time and volume? Again, other than doing procedures, are any of you doing predictations? I'm just now pushing to try to answer this person's question.
I'll do that real quickly, Frank. We don't use ancillary services outside of an operations center. What our approach is to simply automate the informational feeds that fill the header information, right? Automate the detection of critical findings and tie that to an automated dialer. Those are the sorts of things we do. And when I look at other practices, I see a trend of PAs and other ancillary staff coming in to help. They are mostly being put on those very things that we solved with technology. So I would just advise, certainly people are seeing a benefit from ancillary staff, but step back and take a breath and think to yourself, can't I capture that and feed it into my system? Because that is a much more sustainable thing. You don't have the difficulty in staffing and hiring and turnover and training and all that comes with bringing ancillary staff into the equation.
Thanks. Does somebody else want to take that one? All right, well, thank you. I'll turn it over to Dr. Nathan.
Sure. So my question is about recruitment and retention. So in this market, question is kind of how do you outcompete your competitors for talent, and how do you keep good talent in your practice?
Money. No, I mean, you do have to get creative with either signing bonuses, stipends if they are still fellows or in training, the opportunity to do moonlighting in training, creating a positive group culture is obviously a large one, and really figuring out what it is that they want. Right? Why are they looking at your practice? Do they want to be here for geographic reasons? Do they want to be there because they heard that it's good to be part of a large practice or a physician-owned practice? Do they want to, build something new, like an interventional MSK program? So you have to take it on a case-by-case basis. But ultimately, I mean, you're seeing a lot of money thrown around for, recruiting purposes, and that's part of the game, unfortunately.
Well, I
Any other
practice
comments?
at Hershey, and the whole town smells like chocolate, and there's chocolate everywhere. And I think that's our main recruitment and retention strategy, is we're trying to get people who are attracted to chocolate and we get them addicted to chocolate, and then they can't withdraw. It's only been moderately successful.
Any other comments?
Well, I would just reiterate the flexibility that I think most of us have referred to earlier, but it's almost as important to not be so rigid, I think, as to be flexible, because I see a lot of people coming to us that are tired of being, shoehorned into one established workflow, right? I always say it seems that most private practices that are not successful at this are carving their workload into equal slices of pie. And they hand them out to every partner, regardless of age, regardless of earnings needs, regardless of their capabilities. And they say, this is how much pie you eat when you are a member of our practice. And they don't care if it'll choke you, and they don't care if it will leave you hungry. And that lack of flexibility, I think, is factoring into radiologist attrition as much as the offerings of flexibility are helping others recruit.
I think that's a great insight, Ben.
Yeah. All right, I'm going to ask a question that's sort of the other side of the workload issue, which is there any plan to increase radiology residency positions? And I'll add to that other solutions to increase the number of residents, just to expand the question a little bit.
Right. I'll take it first. This is something that we really sort of struggle with. Residency slots are paid for by the Center for Medicaid and Medicare Services, and they set a cap. They're very reluctant to increase that. I think they've added a couple of hundred slots. There's a plan to add another 1,000 slots nationally, but that's to every specialty, and very few of those are going to radiology. I think there's definitely a preference to fund primary care, internal medicine, family practice, residencies with the added slots. On the other side of this issue is, most of us practice that have residencies are in a situation where we have enough volume and we have enough faculty that we could actually add residents. That if we were to petition the RRC and say, look, we'd like to increase our complement by 5 or 6 or 7 residents, they would probably say yes, but we don't have the money to pay those residents, and it's very difficult to increase the complement, in terms of the pay and the cap from CMS. I think the solution is to find alternate ways of funding those resident positions, whether it be from the institutions, from the societies, or from the private insurers. We have a very close relationship with Highmark, for example, and I would love it if they were willing to fund, a slot or two. I think we have to sort of get creative about that. We actually started a new residency in Phoenix, Arizona, when I was out there at Maricopa Medical Center, and we funded 1 slot of the new residents out of our clinical revenue. And 1 slot was through CMS Medicare cap, and we actually adopted 2 residents who came with their own funding from LA County when the Drew program was closed. So it gives you an idea. The timeline of this was back in the 2004, and that's how we got 4 residents to start the residency. That program is doing quite well now, and the residents that it has are funded by the CMS cap, but it took quite a while to sort of build that up. I think it's a real struggle, more from the funding standpoint than others. The other side of this is bringing in English-speaking, qualified, trained radiologists from other countries. We have a very protracted, long, painful alternate pathway for them. If we could streamline that, I think that we could do very well. Of course, they won't love us in the places that we're stealing from, but.
Okay, thanks.
I would jump on that residency topic just to agree with Nick that from my perspective, residencies are underappreciated as recruitment venues. And a lot of people think there's too much lead time. Why bother with residents when it'll be 2, 3 or more years until they come out? And we found the opposite is true, that getting down to the resident class, they appreciate attention, they appreciate education, they appreciate small amounts of funding, and they're great for modern radiology. They come out completely tech savvy. And if you are one of those practices that can offer flexibility in scheduling and in workload, then you'll be perfect for them. I always say the kids love us. And it's, I think, again, underappreciated. I remember when I first came to VRAD 20 years ago, I kept pushing, why don't we talk to residencies? Why don't we lecture to them? Why don't we visit with them and show them what we're about? And it was always dismissed by the higher ups as, being basically too long a run.
Wow, you were ahead of your time, Ben. That's happening now. Our residents, our first-year residents, are being courted by all the practices in our region, and also we're getting a lot of help in terms of teaching them and giving them real-world insights because of the involvement of the regional private practices that come in and speak to our residents.
It's a real symbiotic relationship. We found we create our own CME curricula, and then we can share it in lectures to residents, and that's exactly the kind of thing they're after, and it's very little effort on our part.
It's really good for them because you give them things that the academic faculty cannot.
Yeah, absolutely. They are kind of different worlds. Certainly emergency teleradiology and the standard academic fare.
Dr. Nathan?
Yeah, so do we have time for one more question?
Sure.
Okay, so Dr. Lightfoot, his question was, Flexibility includes generalists reading specialty examinations. However, generalists, whoops, that one just disappeared on me. Whoops,
I can tell you what it said, because I was going to
just
use that
disappeared.
question if I had one more. He was asking about if, we should be sending the subspecialty examinations to the fastest, most expert people, rather than having them taken by generalists who may take longer and may not give as expert an opinion.
I'll take that one. So I don't, and I think most of the people in my practice, we don't segregate studies by CPT code. We may segregate them by indication. So as Nick was, or Dr. Galante was explaining, I'm also MSK. So I might not gravitate towards the post-treatment glioma cases on a brain MRI, but I sure as heck going to jump on a stroke MR from, the 70-year-old that's there for the third time that month. So I think it's a little bit more nuanced than just based off of subspecialty. I think in a community practice, for us, we read for 9 different hospitals, each only a couple hundred beds or smaller. So they're not having the high tertiary level of service from any service line, not just radiology. So, they're being staffed by general surgeons and general neurologists. They don't have subspecialties in the other specialties. So we kind of approach it the same way as a radiology specialty. If I have a difficult case, depending on the time of day, I may just put it back on the list. Or if it's just a small number of people, I might, share the case through one of our apps or something like that. But I think if you already have the culture, or you develop that culture of a general practice, then most people will feel comfortable with most things most of the time. So I think you avoid that trap of having people that are might take too long on a case outside of their subspecialty if you maintain that culture.
And I would add, but you also use the subspecialists, those cutting edge people as your pop-off valve. When you open a case and you look at it and say, gee, I need help with this one, that you can have this two-way traffic of cases. And I think that's also a level of flexibility where you leverage both the efficiency of the generalist and the deep expertise of the subspecialist on a case-by-case basis. And really, it's the generalist that has to be the triage officer for that. You can't do it based on the fact that it's an XYZ type of exam, or the indication is this or that or the other thing. But the generalist would take a crack at it first. And if they think it may be a little bit over their head or they need help, they can reach out to the subspecialist in real time, get a consult, get their question answered. Maybe they can read the whole study, but there's one thing they'd like, another opinion on. And that kind of collegial cooperation, that symbiosis between the generalist and the specialist, I think is really where you're going to get that productivity frontier. And frankly, I think the model requires more generalists than it does subspecialists. And I think you then optimize both. There's a synergy.
Great.
Yeah, I'll quickly add to that, Mike, that we have a kind of a 2-tiered consultation system built into our platform that mimics very much what you're talking about. You can consult someone and it opens up a mutual viewer window, and you can essentially put an arrow on it and type in the chat, what is that? Right. On the other hand, you can transfer a case to someone who's also credentialed in that facility, and they have to accept it. But generally, those go to specialists. And I always say, if you can put your finger on it and say, what is that? That's a consult. If you wave your hands in the air and say, what is that? That's a transfer.
That's great. That's wonderful. But I can tell you, as an ER radiologist myself, I'm often in a situation where I need a deep subspecialist to have a look at something. And I'm fortunate to have friends and colleagues I can reach out to and get those consults in real time.
Okay. Dr. Nathan, do we have to call it at this point?
I think so. I think we're a little over.
I want to just thank the faculty and thank the people who put up the questions. tremendous job by everybody. I want to thank Jen and Anne-Marie, and thank Dr. Pide and Dr. Nathan for all they do for the RLI. So doing this series. So thank you all very much. Tremendous job by the faculty. Thanks again.
Thank you. This has been a lot of fun.
Thanks for attending, everyone. Great questions were submitted, by the way. I wish we could just go all night because there
Part
was
2. We need a part 2.
It's a timely topic. Everyone's really interested about this. Everyone's
I
been
was
affected by
impressed
it.
with the engagement to see all the questions even before we began. So
Yeah, this was a superb program this evening, everyone. Thank you to the faculty. Jen and I appreciate your contributions. Jen and I also appreciate Dr. Lexa co-moderating this evening. Thank you, Frank.
Thanks, Frank.
We also thank the members of the audience for your listening to our program and participating. And we hope that the recording will be helpful to other members of practice. And lastly, we also like to thank our fantastic coordinator for this program, Jen Pendo, and Anne-Marie Pasco for all the help within the RLI. You will receive a post-webinar survey and recording later this week. And to access past RLI Power Hour webinars, you can go to the acr.org/Power Hour site and click on Access Recordings. Again, thank you for a really fine program this evening, everyone. Good evening.
Thank you.
Bye-bye. Bye,
good
everyone.
night, everyone.
Good night.